Has anyone ever told you had fibroids, or did you have an ultrasound that had these big tumors and you weren't sure exactly what to do or what it was? Keep watching and we'll talk today about uterine fibroids because they're a very common cause of abnormal bleeding. Well, welcome back to my channel. My name is duPont. I'm a G1 oncologist. And today I'm going to talk about fibroids. Fibroids are very common and it's a common cause of abnormal bleeding. It's something that I see very often because I also do complex GYN surgery. Now, not all fibroids are treated by a G1 oncologist, but I tend to get referred the ones that are super big. Like I've had patients where their fibroids were so large, it was, up to their liver, or they had a big mass that was extremely large outside of the pelvis. And so those are the cases that I get. But I want you to know that fibroids are very common. They're usually benign. About a third of all reproductive age women will have had fibroids, and about 80% of African American women have had fibroids, according to statistics. Now, fibroids aren't always harmful. Some women have them and they have no symptoms at all. A lot of times they're picked up on the time of an ultrasound done for, a pregnancy ultrasound when they're looking at the anatomy of the baby, or maybe you're pregnant and they just mention that you have some fibroids. I do tell people that typically fibroids, they don't go away on their own. They can grow when patients are younger. So if you're still having monthly cycles, they are responsive to hormones, so they can get larger. Typically, though, in my postmenopausal patients, I tell them that fibroids should not grow, and usually they'll shrink in size. Now, they don't typically disappear in the postmenopausal women, but they should not also grow if you're not having cycles anymore. So let's talk about fibroids. So about a third of all fibroids are symptomatic. So what I mean by symptomatic is that women will have pain or bleeding or symptoms because of the size of the mass. So over the years, I've had women have pain with intercourse because either they had a fibroid kind of near their cervix, or during intercourse, the fibroid was kind of pushed and jarred. So some women will have pain. Most women that I see have bleeding. So that's one of the common causes of fibroids is heavy bleeding. And so that's typically what I see patients on a day-to-day basis. So under the Palm-Cohen system that I've been talking about for the past 2 months, so remember it's like a palm of your hand and a coin. The P is for polyps, A is for adenomyosis, and the L in the palm is for leiomyomas or fibroids. So the typical doctor term is leiomyomas, but we usually call them fibroids. And so there's the same name, but just so that you know, that's what the L in the Palm-Cohen system is. So some other common causes of fibroids, abnormal bleeding, pressure, pelvic pain. And again, some women don't have any symptoms. So just so that you know, most of the time when I see patients, it's usually for bleeding or pain, but you can have fibroids and have no symptoms at all. And fibroids do vary in size. I've seen some very tiny ones and some huge, large ones. So it just depends on, how big they've gotten. I do tell patients that they do have fibroids to make sure you get them monitored, especially if you know you have fibroids, because they can grow over time. So definitely, pelvic exam in the office or an ultrasound, just to keep a check on the size, because, it seems what I tell patients is it's easier to treat things that are small than large. So don't wait until they're the size of an orange or a grapefruit to get it treated. Try to get it treated early if you can, because it's easier to take care of these problems when they're small. Okay, so how do we evaluate for fibroids? Well, typically you can feel them on a clinical exam. Usually the uterus will be irregular shaped. Sometimes you can see the fibroids. I have had patients over the years that have fibroids collapsing out of the cervix, where they're coming through the cervix and you can see them on exam. A lot of times you can feel them because the uterus is just irregularly shaped, or it has like bumps or lumps that you can feel. With transvaginal ultrasound is another way that we pick up fibroids, and that's probably the most common. I have had patients get an ultrasound while they're pregnant, and that's another way we find fibroids, whether that's an abdominal ultrasound. A pelvic MRI is another test that's a very good test for fibroids. Typically the MRI we'll get if we're planning on surgery, because it helps us determine exactly where the fibroids are, and it helps with surgery planning in terms of can we remove it through a hysteroscopy or a little camera that we put in the uterus to remove the fibroid using a device that's associated with the hysteroscope, or do we need to do laparoscopic surgery and open surgery, robotic surgery? There's many different ways to remove the fibroids, but an MRI does help us determine how many there are, where they are located, and it helps for surgery planning. Now, there's lots of treatments. So I kind of tell patients there's multiple treatments. So the first is observation. A lot of fibroids don't need any treatment. They may just need to be monitored. If you're not having bleeding that's bothering you, or pain or anemia, then a lot of times the fibroids don't have to be treated. The second kind of category I talk to patients about is hormonal. So it depends on the patient's age. It depends on what they want to have done. So if it's just for bleeding, the fibroids are small. Sometimes we'll give a younger person like birth control pills. Sometimes we'll place an IUD. Usually one of the hormonal IUDs will help with the abnormal bleeding, especially if the fibroids are small. There's some new hormonal medicines like Myfembry. You may have seen some of the commercials if you're in the United States. Those are medicines that kind of help control the bleeding and can shrink the fibroids. Old treatment that I use very commonly before surgery is GnRH agonist, where I give patients either an oral or injectable medicine to shrink the fibroids. I usually do that for very large fibroids where I'm concerned about bleeding, or if I need to shrink them to be able to remove them easier with kind of a surgery that's less complicated. So sometimes there's injectable medicines we give to kind of make the patient in a postmenopausal state to shrink the fibroids. And then there's those are kind of the most common hormonal treatments. And then also some people that maybe don't have very big fibroids, besides birth control pills, there's progesterone-only pills. There's Depo-Provera, which is an injectable hormonal pill. Some people just need, pain medicine like nonsteroidals will help with the bleeding if their fibroids are small and not causing many symptoms. So, the first category is observation. Second one would be hormonal management. And then the next option would be surgical management. And surgical management varies depending on the patient's age, depends on if they've had their children, depends on if they want more children. And so it kind of varies person to person. So the surgery part is very individualized. So for someone that hasn't had their baby, sometimes a myomectomy is the next best step, and that's where we remove the fibroids surgically. It can be done through a mini laparotomy or an open incision or a laparoscopic small incisions, depending on the size and location. There's also a hysteroscopy approach where if the fibroid is inside the cavity of the uterus, sometimes those can be removed with the hysteroscopy. So those are still kind of in the surgical category. The category that I see and probably that I offer the most is hysterectomy, because most of the time when I'm seeing a patient, they've had their children. A lot of times they're older, sometimes they're postmenopausal. So for those patients, I offer them typically a hysterectomy. I usually will try to save the uterus if they're young and they haven't had their babies yet. But a lot of times I'm getting patients that have the really huge fibroids, size of a basketball or grapefruit. So I kind of get the more complicated ones. So for them, most of my patients will go for hysterectomy. There are some newer techniques also that can treat fibroids. There's a uterine fibroid radiofrequency ablation, which is the accessive procedure. I don't do that, but it's a very good option for some patients. It doesn't treat all fibroids, and I don't think it works well for very large fibroids, but it is an option. I have over the years had patients get uterine artery embolization, and that is very good for some patients, not all patients. So definitely, if you want to keep your uterus and you don't want to have a hysterectomy, but you want some way to stop the bleeding and you're done having your children or you don't want children, then uterine artery embolization may be something for you. Definitely speak with your healthcare provider. It does have risk and benefits, and I have had over the years a few patients that had a uterine artery embolization and then still had to have a hysterectomy later. Now that's not common, but I have seen it over the years. Just keep in mind that that's just another kind of tool in our toolbox. Then in terms of hysterectomy, that means removing the uterus, and that can either be done vaginally, laparoscopically, robotically, or open, depending on the size of the fibroid. The one thing that I do talk to my patients in the office who have fibroids, especially women that are older or who have super heavy bleeding, I do tell them that there is a small risk of something called a leiomyosarcoma. Now, that's not a fibroid, but sometimes it can be misdiagnosed as a fibroid. So a lot of times if I have someone where I'm really concerned about a uterine sarcoma, I will get an MRI and then I will talk to them about a hysterectomy. Sometimes we don't find out until after where we've already done the surgery and someone has a cancer. And so in that case, they have to get, treatment for the cancer, whether it's with chemotherapy. But we do try to make sure patients know that, even if you have fibroids and you don't want, hysterectomy or surgery, they still need to be monitored to make sure they're not growing. So fibroids that are rapidly growing typically aren't fibroids, and sometimes they could be leiomyosarcoma. So just keep in mind that if you do have what we think may be a fibroid, but it's not acting right, or you're bleeding a lot more than what we expect, then talk with your healthcare provider and make sure you get an MRI and make sure someone's thinking about leiomyosarcoma. We don't see them often, but they are very aggressive and typically they grow rapidly. And so those are ones that we need to be monitored, and those typically won't respond to kind of the hormonal type of medicines. And so those need to be removed surgically with a hysterectomy. But anyway, most women will have just benign fibroids that typically are slow growing and typically are easily managed. But if you do have them, see your healthcare provider and see your provider on a regular basis, because even if you don't want surgery, you definitely need to make sure you're followed to make sure the fibroids don't get too big. I hope this has been helpful for you. If you have any questions, please leave them in the comments below, and I'll see you next time. Thank you for watching to the very end. Bye-bye.